Okay, so metabolic disorders of bone. So bone is a living structure. So some people think bones are like the scaffolding of the body, which are like um, only structural and dead. But bone is a living structure. There is a continuous activity in bone during all stages of life. There's continuous bone resorption and bone formation, as well as remodeling. That means bone is not only for protection and support, but its contents play an important part in blood homeostasis. Many factors are involved in this process, such as those controlled by many factors: calcium, phosphorus, parathyroid gland, the thyroid gland, estrogen, glucocorticoid hormones, intestinal absorption, renal excretion, diet, vitamin D, and sun exposure. So bone structure, the bone is formed of bone matrix, which consists of 40% organic. Okay, so 40% of the bone matrix is organic and is collagen type 1, which is responsible for the tensile strength. 60% is minerals, mainly calcium, hydroxyapatite, phosphorus, and traces of other minerals like zinc. Cells in bone are osteoblasts, osteoclasts, and osteocytes. Plasma levels of some minerals. Calcium, normal is 2.2 to 2.6 millimoles per liter. Phosphorus, 0.9 to 1.3. Both are absorbed by the intestine and secreted by the kidney and urine. Alkaline phosphatase is usually 30 to 180 units per liter. It is elevated in bone increased activity. So if there's high turnover in the bone, like during growth or in metabolic bone disease or destruction, this level becomes high. Normal vitamin D level is 70 to 150 nanomoles per liter. So parathyroid hormone. The parathyroid hormone production levels are related to serum calcium levels. So parathyroid hormone secretion is increased when serum calcium is low. The action of PTH is increasing calcium levels in the blood. How does it do that? It increases its release from the bone. So it releases calcium from the bone into the bloodstream and increases absorption of calcium from the intestine. It also increases reabsorption of calcium from the kidneys and increases secretion of phosphorus. When you have hyperparathyroidism, this is 3 types. You can have primary hyperparathyroidism caused by an adenoma of the parathyroid gland, or secondary hyperparathyroidism as a result of low calcium. So if you have a reason for low calcium in the blood, the parathyroid gland will secrete more PTH. Or tertiary as a result of prolonged or sustained stimulation, such as hyperactive nodule or hyperplasia of the gland. Okay, so calcitonin now. Calcitonin is secreted by the C cells of the thyroid gland. Its secretion is regulated by serum calcium again. Its action is to cause inhibition of bone resorption and increasing calcium excretion, lowering serum calcium. So it has an opposite effect to PTH, okay? Bone strength. Bone strength is affected by mechanical stress, which means exercise and weight bearing. So bone strength is reduced with menopause and advancing age. Reduced bone density on x-rays is called osteopenia. Osteopenia is also a term used to describe a degree of reduced bone density, which if advanced, when it advances, it becomes osteoporosis. So bone density is diagnosed at the current time by a test done at the radiology department called a Dexa Scan. Okay, you cannot diagnose osteoporosis or decreased bone density on an X-ray. You need a Dexa scan. Dexa is short for dual energy X-ray absorptiometry. However, increased bone density doesn't always mean increased bone strength. So sometimes, such as in osteoporosis, you have very dense bone, and it is not a strong bone, but very fragile bone, which may break easily. Okay, so bone density has to be balanced, not very low or very high. So this is what a Dexa scan report looks like, and there are some common areas where we measure bone density, such as the lumbar vertebrae in the spine and the femoral neck in the hip. Okay, so disorders that we will be discussing now are rickets, osteomalacia, osteoporosis, and hyperparathyroidism. So first, we'll talk about rickets and osteomalacia. They are different expressions of the same disease, so rickets and osteomalacia are basically the same thing. They are both inadequate mineralization of bone. Rickets, what's the difference between them? Rickets affects areas of enchondral growth in children. Okay, so where the cartilage is turning into bone. Osteomalacia affects the whole skeleton in adults, and all the skeleton is incompletely calcified in adults. Causes of rickets and osteomalacia, so it can be caused by calcium deficiency or hypophosphatemia or defect in vitamin D metabolism. So defect in vitamin D metabolism can be caused by nutritional deficiencies, underexposure to sunlight, intestinal malabsorption, or liver and kidney diseases. So first, rickets. In rickets, the symptoms and signs, the child is restless. If it happens in a baby, the baby cries without obvious reasons. They have a failure to thrive, so they don't grow normally according to their milestones. They have muscle weakness. In severe cases with very low calcium, they may even have tetany or convulsions. Joint thickening, especially around the wrists and knees. Deformity of the limbs, mostly Genu Varum, okay, or Genu Valgum sometimes. And this is, so what Genu Varum means bowing of the knees or legs, and Genu Valgum means knocked knees, okay? They can get something called a pigeon chest deformity, where the chest protrudes outwards, a ricket rosary, and craniotabes, where the head enlarges, okay? The skull also becomes involved, and the skull becomes large. So these are the common areas of where rickets can be seen: around the knee, the skull, the ribs. They get the rickety rosary around the ribs, and the wrists. So this is what a child with rickets may look like. You can see the main thing is the Genu Varum. So the legs are bowing, the knees are in varus. The rickety rosary, you can see the protrusions along the ribs, and craniotabes means an increase in the size of the head. X-ray findings in rickets: the growth plates are widened and thickened. The metaphysis becomes cupped, so they have metaphysial cupping, and they have long bone deformities, as we said, varus or valgus. Most commonly, it is varus. So you can see here the growth plate is widened around the knee, and the metaphysis has cupping, so like flaring, okay? Long bone deformities, again, here you see the femur is severely bowed. The femur is supposed to have a slight bow, but mostly straight. But you can see here how there's a severe curve in the distal femur. Okay. Okay, so biochemistry. What do we find on biochemistry with patients who have rickets or osteomalacia? There is hypocalcemia because they have low calcium in the blood, and hypocalciuria, low calcium in the urine. And they have high alkaline phosphatase because there is high activity in the bone, which is being depleted of calcium. So osteomalacia is a metabolic bone disorder in adults. Symptoms and signs include bone pain, mainly backache, muscle weakness, reduced bone density, vertebral changes. So in the vertebra, you can have biconcave vertebrae, vertebral collapse, or kyphosis. You can get stress fractures. So you can get something called looser zones in the scapula, ribs, pelvis, and proximal femur. Looser zones are areas of radiolucency. Okay. So these are the areas where osteomalacia targets the most in adults. So the vertebrae, the pelvis, proximal femur, the scapulae, and the ribs. This is a lateral X-ray of the lumbar spine showing biconcave vertebrae. So the top end of the vertebra and the bottom end, instead of being straight, they become concave. This is a stress fracture in the proximal femur. You can see at the base of the femoral neck, there's a small black line, and that is a stress fracture because of osteomalacia. Okay, as a more severe case now, you can see the biconcave vertebrae, but there's also a stress or compression fracture in one of the vertebrae causing severe kyphosis in the thoracolumbar spine. So how do we treat these? The treatment depends on the cause. So if they have vitamin D deficiency and rickets, we give adequate vitamin D replacement, sun exposure, and correct the residual deformities. In osteomalacia, we give vitamin D and calcium. If there's fractures, we manage the fractures. And if there are deformities, we correct the deformity if needed. So this is a patient who had rickets as a child and has residual deformity. In the right knee, they have a Genu Varum. So you can see the proximal tibia is curved with the tibia pointing now towards the middle of the body. So this is Genu Varum. And the left knee is the opposite. The knee is in valgus. Okay, so varus on one side and valgus on the other side. So this is how we correct Genu Varum. If they have varus, we perform an osteotomy. So we cut the bone, correct it, and fix it with. There are different ways of fixing it. In this situation, we use the plate and screws. Correcting Genu Valgum usually is with a distal femur osteotomy. So you can see here the distal femur was osteotomized or cut. The deformity was corrected and it was fixed with plate and screws. Okay, now moving on to osteoporosis. Osteoporosis is decreasing in the bone mass, decreased amount of bone per unit volume, and this causes reduced density. Mineralization is not affected, so osteomalacia and rickets is because of decreased mineralization. However, in osteoporosis, that is not the case. Mainly, it is postmenopausal and age-related. So if you look at a section of bone, on the left side, this is normal honeycomb pattern. On the right side, you see the honeycomb pattern with big holes in osteoporosis. So you can see how it has less density. And this is what a section in a vertebra looks like in osteoporosis. You can see the decreased density, the big holes, and you can see why they have decreased bone strength and easy to fracture. So osteoporosis may be primary or secondary. Primary osteoporosis is usually postmenopausal or in old age, which we call senile osteoporosis. Postmenopausal osteoporosis is due to rapid decline in estrogen levels. It results in increased osteoclastic activity. So, as you know, the osteoclasts are responsible for bone resorption. Normal bone loss is usually 0.3% per year in a normal patient, but postmenopausal bone loss is 3% per year. So that's 10 times the normal. Risk factors for postmenopausal osteoporosis. Some races have a higher rate of osteoporosis than others. Hereditary, so if they have a family history. Body build, early menopause. So if the patient has early menopause, she's more at risk of osteoporosis. Smoking, alcohol intake, and drug abuse also contribute to osteoporosis. Calcium intake is still debatable whether it causes osteoporosis or not. So senile osteoporosis, usually by the 7th to 8th decades, so when the patient is in their 60s or 70s, there is a steady loss of at least 0.5% per year. It's part of the physiological manifestation of aging. Risk factors include dietary, so less calcium and vitamin D and protein, muscle weakness, and reduced activity. So, as we said, bones become stronger with more stress placed on them. So, if you have stronger muscles and do more exercise, there's more loading on the bones and they become stronger. If you have reduced activity and reduced muscle weakness, the bones will also become weaker. Clinical features of osteoporosis. Osteoporosis is a silent disease, okay? So it is serious due to possible complications, mainly fractures. Osteoporosis does not usually cause pain, okay? And causes gradual increase in dorsal kyphosis. So that's why you see patients who are older patients who have kyphosis and they are leaning over. Osteoporosis leads to loss of height, so they become shorter, and it is not osteoarthritis, okay? But the two conditions may coexist. So the same patient may have osteoporosis and osteoarthritis, but they are two different diseases. So this is why patients develop kyphosis if they have osteoporosis. You can see how, again, the honeycomb appearance, the trabecular bone in osteoporosis is decreased, so the vertebrae become weaker, and they have these crush fractures or compression fractures. And when you have several compression fractures adjacent to each other, the the whole spine goes into kyphosis, okay, forward bending. So this is how it occurs. Like we said, when you have multiple compression fractures, the spine curves anteriorly, okay? So you see how this patient started off with a straight back and slowly with osteoporosis and multiple compression fractures, she has developed kyphosis, which is forward bending of the spine. Okay, so osteoporotic fractures are pathological fractures. The most common is an osteoporotic compression fracture in the spine. Vertebral microfractures occur unnoticed, so they have no severe pain, but they have a dull ache in the back. Most serious is the hip fracture. So if they get a hip fracture, that is the most serious and life-changing. Also very common is wrist fractures from low energy falls onto the outstretched hand. And the most common is called the Colles fracture. Okay, so now moving on to secondary osteoporosis. Usually, so it's due to a secondary cause. It can be drug-induced, so the drugs that can cause osteoporosis, steroids, alcohol, smoking, phenytoin, and heparin. Hyperparathyroidism, hyperthyroidism, Cushing's syndrome, gonadal disorders, malabsorption, and malnutrition can all cause osteoporosis. Chronic diseases such as rheumatoid arthritis, renal failure, and tuberculosis can cause it. Malignancy can also cause osteoporosis, such as multiple myeloma, leukemia, and metastasis. So you can get something called disuse osteoporosis. It usually occurs locally adjacent to immobilized bones or joints. May be generalized in bedridden patients. So if a patient is bedridden and cannot get out of bed for long periods of time, they can get disuse osteoporosis. Awareness of this condition and attempts for prevention are helpful. So what's the difference between osteomalacia and osteoporosis? Osteomalacia can happen at any age. The patient is ill, they have general aches, weak muscles, looser zones on the x-ray, they have high alkaline phosphatase, and decreased phosphate in the serum. Whereas osteoporosis usually happens in postmenopausal ladies or older age in general. The patient is not ill. They are usually asymptomatic until they get a fracture, and the fracture obviously is symptomatic. The muscles are normal. There are no looser zones on x-rays. Alkaline phosphatase and phosphate levels are also normal. How can we attempt to prevent osteoporosis? So prevention of osteoporosis should start from childhood by having a healthy diet, adequate sunshine or sun exposure, regular exercise, avoidance of smoking and alcohol, caution in steroid use, so only use steroids when needed. At some time in the past, there was a recommendation of hormone replacement therapy for postmenopausal women, but now this is discontinued because of risk of developing malignancies. So when a patient has and is diagnosed with osteoporosis, how do we treat it? So we treat it with medications, with exercise, and if they get fractures, we treat the fractures. What kinds of medications do we give? So estrogen has a definite therapeutic effect and was used in the past, as we said, but cannot be recommended now due to serious possible side effects. Adequate intake of calcium and vitamin D is mandatory. Drugs which inhibit osteoclast activity can be given, such as bisphosphonates. One example of bisphosphonates is alendronate. The commercial name is Fosamax. It's one tablet taken once weekly. The other one is denosumab, or the commercial name is Prolia. It's a subcutaneous injection every six months, and it is composed of human monoclonal IgG2 antibodies. So drugs which enhance osteoblast activity. So you have two options. You can give the drugs we talked about, the bisphosphonates or denosumab, which inhibit osteoclasts, or you can give drugs which enhance osteoblast activity. And these are bone-stimulating agents like Forteo. Okay, Forteo is a commercial name. The scientific name is teriparatide. So exercise. What about exercise in osteoporosis? Resistance exercises are important. Weight-bearing exercises are important because we need to load the bones. Exercise should be intelligent to avoid injury, which may lead to fracture. Okay, so we have to be careful with exercising patients with osteoporosis. We use load-sharing implants. So when we manage fractures in osteoporosis, we want to make sure we use load-sharing implants when we are doing internal fixation instead of plating. Okay, so examples of load-sharing implants are intramedullary nails. So we try to use nails as opposed to plates and screws in patients with osteoporosis as much as possible. Okay, excuse me, I have to stop for a second here. Okay, so let's continue. Okay, so management of fractures, uh, pain relief, prevention of further fractures, prevention of instability, vertebroplasty or kyphoplasty. Okay, so this is for um, compression fractures of the vertebrae. Okay, now we'll talk about hyperparathyroidism. This is excessive PTH secretion. It can be primary, secondary, or tertiary. It leads to increased bone resorption and subperiosteal erosions, osteitis, which is manifested by fibrous replacement of bone. Significant features, the significant feature is hypercalcemia, so high calcium in the serum. In severe cases, you can get osteitis fibrosa cystica and formation of brown tumors in the bone. Radiological changes in hyperparathyroidism, you see a generalized decrease in bone density on the X-ray. There's subperiosteal bone resorption, and that causes scalloping of metacarpals and phalanges. You can get brown tumors, as we said, and you can get chondrocalcinosis, okay, in the wrist, knee, and shoulder. So that's formation of uh, cartilage and bony loose bodies around the wrist, knee, and shoulder. So here is an X-ray of a knee showing decreased bone density, and here's an X-ray of a hand showing scalloping of the metacarpals and phalanges. If you look at the phalanx of the index finger, medially, there's some scalloping, which looks like someone took a bite out of it, okay? And that is the bone resorption, the subperiosteal bone resorption causing that. And here you can see on the right tibia, in the middle, there's a large radiolucency, and that is a brown tumor, okay? And in the other parts of the tibia, also in the left tibia, you can see the cystic formation. This is what chondrocalcinosis looks like. So you can see on the left wrist, this big calcified foreign body or loose body, okay, and that is caused by hyperparathyroidism. How do we manage it? Management is by treating the cause of it. So primary hyperparathyroidism is due to a neoplasm or adenoma or carcinoma. So that needs to surgical excision by a general surgeon. Secondary hyperparathyroidism is treated by correcting the cause of hypocalcemia. Tertiary hyperparathyroidism is treated by excision of the hyperactive autonomous nodule. Extreme care should be applied after surgery to avoid hypocalcemia due to hungry bone syndrome. Okay, so once you treat it, you do the surgery, there's no more hyperparathyroidism. Now the bones want to gain back all the calcium that they have lost, and calcium is very fast and very rapidly shifted back into the bones, so you can get severe hypocalcemia in the blood, and you need to make sure that you look out for it and treat it. Okay, so that's it for our lectures. Any questions?